to end the day, we're going to have this really great panel discussion. Okay, I'm going to introduce our panel, and then I'm going to ask some questions. So we have Lauren Day here, so thank you for being here. A patient. We've been waiting to hear from patients all day, so I'm going to ask you a lot of questions because I know a lot of people are raring to hear from patients. Howard Lux is here. He's a blogger extraordinaire and is on Twitter. He's everywhere. So thank you for being here. And Dr. Tamimi joins us again for the panel. If I can ask the panelists to use the microphone because it's being recorded, and so we can capture that, and so everybody can hear what you're saying. So let me start with you. So social media. Let me start with the really tough and hard question. What drew you to social media? How do you utilize social media? Tell us a little bit about your story to start out.
So my story, again, my name is Lauren Day. My story is actually a little backward. My physician introduced me to social media. Full disclosure, it's Howard. So, but he introduced me to it 12 years ago when it wasn't called social media. It was this new thing called an internet. And I was finding that I wasn't getting the kind of care I wanted locally. I wasn't in a big city. I was kind of out in the middle of nowhere, Pennsylvania. I think that after enough bugging of the physicians that I was not getting the results I wanted from, they said, we'll post you to this website. And Howard picked me up. But from that, not only did I have a great experience, and I got back to the kind of activities that make me keep coming back to Howard for 12 years, it introduced me to the idea that you can be involved and empowered with your own health care. You can be engaged with information. And as my patient-physician relationship evolved, so did Howard's involvement with social media. A couple years later, I'm skiing and I blow out my knee again. I look up Howard to find his phone number, and lo and behold, he's on Facebook. And then he's on Twitter. And I sign up for Twitter to follow Howard. But in doing so, I also am having other reasons to see physicians. I have a little 2-year-old daughter, and I needed a pediatrician. So instead of just looking who my healthcare provider allowed for pediatricians that covered, I actually first looked up who in my area was involved in social media. I found a pediatrician that blogged, and then I went and saw and made sure that she was in my healthcare. So
why is that important to you? Why is it important that people, your providers and physicians are out there?
I like that it humanizes it. Howard already said it before. I want him to know I'm a person. I want my pediatrician to know my daughter's, a person, and not just whatever disease or ailment is bringing me into the office. And I also want to know that they're a person. It's nice to know that it brings us all on the same level. I'm able to go in there. I'm a little calmer coming in to talk to the pediatrician about vaccinations. That's the big buzzword. Before I show up, I looked up vaccinations. She was 2 months old, and I walked in and I said, okay, this is what I saw on your blog post. Just tell me a little bit more information about it. If that pediatrician didn't have that blog post, I still would have come into her office with something. I was going to come into something I found on Google, and then she was going to have to explain it from somebody else's words. So I really appreciate a physician on social media because it's their words first that I'm getting answers to.
Let me bring Howard into the conversation. I know you've been raring to talk all day. we've been talking in the corner the whole day.
Hard to keep me quiet.
I know. So why is it important for you, to be on social media? Why is it important that you think physicians should be on social media?
Education.
Okay.
I am, like you, a full-time practicing physician. I am an orthopedic surgeon. I've been involved in social media, I was involved in the internet before it was even termed social media or even digital media, with the goal of leveling the playing field, giving you the information that you need to inform you of what evidence-based medicine was available, so that you understood that most of what was appearing online is a lot of commercialized nonsense. The Laser Spine Institute, or this spine ad that I just saw appear on Twitter a few hours ago with spine surgery works. It doesn't. And most people with meniscus tears don't need surgery. Yet most people treat MRIs, they treat x-rays, they don't treat patients. I want to hear your story, because I'm going to treat someone who's a triathlete, who is running from 5:30 in the morning till 7 in the morning, and then again, they're in the pool when they get home, a lot different than I'm going to treat the unemployed couch potato who gets out of bed, grabs a beer, sits in his chair, yet they both have the same meniscus tear or ACL tear or whatever, sitting on a couch. I'm sorry, from whatever injury. I need to know your story. And you cannot treat an isolated finding. You need to treat a patient. I need to know your story. And I wanted you to know that is the way that medicine should be practiced, and that this is accurate, evidence-based information. This is up-to-the-date information, and I want you to be able to make appropriate decisions for yourself. Not only if you're present in my office, but I talk to patients all around the world.
Okay, great. You talked a little bit this morning. Let me ask you maybe to expand a little bit about specifically patients, like how patients help tell the story of the Mayo Clinic and how the Mayo Clinic helps tell the story of patients using social media, because a lot of patient testimonials on the Mayo Clinic site, and it's fascinating how you've gotten to engage with patients to do that. Can you speak a little bit about that?
So, it's an old argument. It goes back over 25 years to data from the Pickering Institute looking at the archetype of an ideal patient encounter. And what is an ideal patient-provider encounter? And it's evolved into a shared decision-making model where we make decisions with our patients, and one we practice predominantly by guideline-based medicine. We make decisions for our patients. And when you look at simple endpoints, like after a heart attack, number of patients who are on the 4 drugs that make you live longer at 1 year is less than 50%. The reason they're not on them is they get home and encounter issues and concerns relating from, in my mother's case, people who get their hair done with her, to people they meet at the pharmacy, people meet online, regarding what may happen with those medications. Our problem is when we engage those patients, we tell them, here is a statin, you need to be on it. Which is a different conversation than saying, of the 100 people who are just like you in the next year, 30 will have a recurrent event. We'll put you on a statin, only 10 will, but 1 or 2 will have a muscle problem or some liver problem. What would you like to do? Do you want to take the risk of be one of those 1 and 2 and not be one of those 20 who didn't have a heart attack? Now that's the intimacy of the patient-provider interaction.
Sure. What
you're referring to is bringing the patient into policy procedure development at all those institutions. And I think we've all seen the value in doing that. Patient advisory councils, which you use in family medicine to an exhaustive extent, have been profoundly valuable at looking at patient satisfaction data, patient compliance data, patient comprehension, healthcare literacy. Extending those conversations to the digital domain is a powerful thing to do. I will say one thing. I don't have Howards. I would love to have a lot of you if I could, or even one of you if I could. So many of my conversations are much more difficult with providers who have concerns regarding time, regarding the ability to engage, regarding the risks. And I'd like to hear from Howard. I'm sure you encounter those sorts of conversations on a regular basis. How do you respond to providers who say, I don't have the time to do this, I'm worried about the risk of doing this, I'm too scared to do this?
He loves this question.
I simply tell him it's important. It's very important. We are here to treat patients. The root word of doctors docere is to teach. I am here to teach you, to educate you about your disease process, and to enter into a shared decision-making process with you, similar to what Ferris articulated, so that you can make the proper decision. And even after I spend, it's interesting, 15 minutes with someone and engage with the patient, they'll still turn to me and say, what would you do? I say, I really can't answer that question, especially in my line of work, where you don't have a 30% chance of dying in the next year if you don't have your meniscus repaired. You might have pain. However, I can't tell you if your quality of life is altered enough that you need surgery. You can tell me that, and you need to. Now, what do I tell other physicians? I tell them that the world is changing. The way the patients are communicating, the chart and graph that Chris has shown us today, how those very active patients and people are starting to influence those who don't show much of an interest. Well, those who don't show much of an interest will if they have knee pain and can't walk, I assure you. And they're going to fly across that graph and become very interested very quickly. And if you are not active, and if you are not out there, and if you are not where patients are looking for information and online, then your relevance going forward as a practicing physician is in question. Is that in the next year or two? No. But going forward, 5, 10 years, as the e-patient movement and as medicine changes, I guarantee you that your relevance as a physician is in question if you do not seek to engage patients, produce content, and are willing to take the time and then give the patient the time that they deserve to make a meaningful decision based upon how that disease is influencing them, or what I call the personality of an injury. Again, how that injury is going to exhibit itself is going to be different in you versus you versus you versus you, yet you have the same MRI finding.
Let me follow up on that, because I want to ask you the how, because I get a lot of questions about how physicians and providers can do this, and I've heard you speak before, and I enjoy how you kind of break down inbound versus outbound. Can you talk a little bit about how you do inbound social media and outbound social media?
I do very little in the way of outbound modalities. Most of what I do is has an inbound objective, to it. I simply put the information out there on my website, and then I utilize social media aggregating tools, and I do stutter, so forgive me, and it's not nerves. And I'll put the information on Twitter, I'll put it on Facebook, I'll put it on, I was probably the first doc on Pinterest, and I will put it anywhere and everywhere that I possibly can, because social media use is cultural. Many different age groups or ethnic groups are going to use different forms of social media in their own ways. And so one social media medium does not suit all people.
Yeah, let me follow up on that too. Is that so you utilize the Twitter aggregator called Hootsuite.
Correct.
Can you share a little bit how you use that in your social media workflow?
Because I'm a full-time practicing physician, and that is my means of generating income, my only means of generating income, a lot of people ask me why it appears that I'm so busy throughout the day, and it's because of Hootsuite and a lot of these platforms. I'll get to work pretty early in the morning, 5:30, 6 in the morning.
After your bike ride or after your jog?
After some form of exercise,
There you go.
or down in our physical
All
therapy gym. And I'll load up Facebook posts and Twitter posts that are going to appear throughout the day, via the scheduling app.
So you schedule tweets to go out.
I schedule tweets to go out.
All
I
right.
schedule blog posts to go out.
All right.
If I come up with a blog post at 11 o'clock at night after my kids are finally asleep, I'm not going to post that at 11 o'clock at night. So I'll schedule it to come up at 7 in the morning. I'll schedule the tweets to go out at 8 in the morning, 3 in the afternoon, 5 in the afternoon, etc.
Okay. Let me come back to Lauren, because I got a couple of good questions on Twitter, and about patients trying to engage with their physician or provider about maybe not using social media, but finding information on the internet. I know it's easy because you have many providers that do that.
He's not my physician for everything. He's not my
That's right.
pediatrician.
That's right.
So,
But for those patients out there, what advice do you have to at least start the conversation or try to engage their provider or physician on talking about the internet, talking about social media?
I think that I've actually found much resistance to it. I think that often I find physicians are assuming I'm trying to sell them something. So my approach has been, when I have found a physician who I find engaging, and I would hope to see them more involved, and I could see just myself personally benefiting from it, but hope that they could see the light and enjoy the moment too. is that I try and tell them that I'm going to come into your office with information, and it's going to be either information that I find on Google and it is completely unfounded, or I can come in with information that you've provided me. So that seems to give a good sort of reality into the conversation we're going to have, because and then it actually opens up a nice discussion, because they'll say, oh yes, Dr. Google is my every third patient. So I do though think that I have to get past that it's not just a marketing tool.
Okay.
That is a good benefit that one can receive from social media, but that it is not, I'm not coming at them for the primary goal of them marketing themselves to me. It's really information gathering.
So as a consumer of social media, especially in healthcare, do you have a process by which you judge sites, or how do you figure out yourself what are good sites or bad sites, or do you ask other people, or do you look to Twitter or Facebook? How do you do that?
Well, I would say that right now any physician-based site that I find is usually the best source. If I find any other information that's either product-based or is coming out by often what I find either on a hospital or healthcare provider's website is so minimal that I find that it's just feeding me basic information, and that from that I will go into a massive Google search to see whatever I can find out about that physician. So, if I noticed that they graduated from medical school at a certain time frame, then I will search them with that graduation date so that I can get more specific information about that physician, rather than just being fed very basic information that's not providing me any detail.
Okay.
I just want to add one thing.
Yeah, go ahead.
Because we're right in a good point in this conversation. A lot of doctors are afraid of these Google patients and these helicopter patients, and Loring is not like that. Loring comes into the office quite educated.
Yes, you can talk about
Thank you.
I give them full.
And these are not extended 45-minute discussions. She doesn't come in with reams of papers. She comes in very educated and with very directed questions. And the questions are written out. She's ready. She's prepared. The exam takes place, and the discussion begins. And it is not a longer discussion than I have with anyone else. It is a far more useful and educational discussion for both of us. And it is a lot easier for me because she knows the background information. That's part of the ROI. That's part of the ROI that I recognize without needing to recognize it. I don't need an ROI. I'm there for altruistic reasons. I'm there to teach you, and I'm there to educate you, period, end of it. Yet there is an ROI to having a very educated patient sit in front of you, a very engaged patient, because she's much more comfortable. She's not afraid of me or what I'm going to say. She's comfortable with me. She's seen my videos. And same with you, if you are, if you are researching an orthopedist, you land on my website. Unfortunately, you see this video with my mouth is open because I don't know how to edit videos very well. but yet, it welcomes you to the website and invites you to explore it. And there's videos all throughout the website, and they're just calm and informative. And they're not saying you need surgery, you need surgery, you need surgery. It's guiding you in the decision-making process. And that generally comforts the patient enormously. So those first 3 to 5 minutes of the interaction between a doctor and a patient are no longer edgy. They're no longer uncomfortable. So you get into the meat of the matter, the heart of the matter, very quickly. And the patient has also read the content that they've typically diagnosed themselves, either through WebMD or your own website. And now they have already read through the content that's on my website, so they know what I'm going to say. And so the conversation has already begun without it beginning. Mm-hmm. And yet, so when I engage them and start the discussion about the treatment alternatives available, they know what's coming next. So it can be a shorter visit, yet a far more effective visit. Mm-hmm. So there is an ROI there from an individual practitioner's perspective because you can actually see more patients. And although, again, I'm not in this for the money. Your conversion rate is going to change in terms of surgical conversions. because the patient is educated, et cetera. So they've typically already made up their mind to, to one degree or another in many instances.
Yeah, I'm going to ask Dr. Tamimi a question, but after that, I'm going to open things up because I know that probably people out there have a lot of questions for this great panel. So let me ask you, because you're a data guy, you're a research guy.
A data or a daddy? Which one?
There you go. I have patients ask me a lot, because they get intimidated, with trying to look at research and trying to read research. They want to be empowered. They want to learn about that stuff. But do you have advice specifically for patients on how to try to, learn more about their condition? But if they go into the, look into the research to talk to their physician about some of these specific, treatment things, you have advice for them as far as how to try to learn how to do that, or learn this research speak, or to learn how to, to see what the best treatment would be for them?
I'll tell you, first of all, that the majority of patients and their desire to share in decision-making is related inversely to the acuity of their illness. So the more critically ill they are at that moment in time, the less they're going to want to make a shared decision with you. The more the illness moves to chronicity, the more they're going to want to discuss things fully. And part of what providers need to understand is to be able to read the patient's need for engagement at the moment in time, and engage with them appropriately. Because when they're critically ill, they want. When my wife was in labor with our first child, we labored for like 9-10 hours. She was on all fours, and the senior resident whom I'd worked with before in a training model came in to say, we need to decide what we should do. You should decide, do you want to have a VAC, forcep, or a C-section? What's best for your needs?
Right.
And I took the consultant outside, and I said, dude, if you were infarcting, I would take care of you. Tell me what the hell to do with my wife, because I can't make a shared decision right now.
Right, exactly. Right.
And it's not because I'm not capable. It's because at that moment I need someone to come in and take control of the situation and make things right for me. So the first thing the providers need to understand is how to partner with patients effectively by reading them effectively. In regard to your question regarding the veracity or quality of data, I think part of what you said is quite logical. I mean, data provided by providers in general has an aura of credibility and value. I do direct patients to our websites because I think our content is well made, and I think our content has value, and I think our content meets their needs effectively. Quite frankly, although I hate to admit it, Wikipedia does a reasonable job providing data that I find useful as well, and I'm not afraid to use that when I'm meeting with patients either.
Can I speak to
Yeah,
that
go
point
ahead.
a little bit?
Sure.
So actually Howard reminded me. I had an emergent situation. Usually you don't hear that often with orthopedic injuries, which is the primary cause that got me involved in all of this. But I ended up in an ER in Philadelphia, and I was a deer in headlights. Here I am, up here to speak about being this educated patient, and I'm empowered, and I have all this information, but I had an infection that needed to be dealt with immediately, and Howard was getting some texts at a slightly ungodly hour on a Saturday that said, he actually called me and said, are you doing okay? I was like, well, no, I'm a little overwhelmed. I have residents, and I don't know who the attending is, and they're talking surgery, and it's just, what does this all mean? And I couldn't make any shared decisions. I actually had to have information fed to me. Afterwards, I could go through the process of learning about what the situation was that I was in, but I had, I didn't need to be in control of the situation. I had to have the situation controlled for me.
That's a good point. I'm going to open up because we have a lot of time for questions. Yeah, go ahead.
So I'm Jonathan Streeter with the New York City Public Hospital System, but this is a personal anecdote. I moved to New York City last year. I'm a big runner. I ran about 2,100 miles last year. And I just moved to New York City, and I'm obviously in the healthcare system, right? But I tore my plantar fascia, and I went to Yelp.
And why did you go to Yelp?
Because I don't know anybody in New York City other than people in my office.
Okay.
Who would never torn their plantar fascia, right?
Okay.
So,
Okay.
right? I mean, that's how I picked my position. I mean, I didn't even care whether they were part of my network because I just wanted to go to somebody who really helped. What I wanted to do was I wanted to run again.
And what kind of content did you get from Yelp?
It's what's really interesting about Yelp is mostly people comment positively when it comes to medical. So there was either just no data or just some positive data, and I picked the group because of that. But I did add a Yelp review after my experience, and we haven't talked about that as part of social media, but that's from our consumers. That's actually, it's really huge. They're not just looking for pizza; they're looking for to get their plantar fascia.
Okay. Okay. Other comments on that comment?
You know, we have a large group. We're 13 providers. We have one provider in our group who patients don't like to go to because of his bedside manner. Please don't tweet this.
Oh, it's tweetable.
Even though
it's
he's
out there. Yeah. Boyer's all over it. He's going to write a song about it actually later.
And I got to tell you, you go to his health grades page, and it's scary. It's amazing that anyone shows up in his office. He's a great hand surgeon. Oops.
Yeah, let me follow
So
up.
there are patients who will write critical reviews.
Yeah, let me follow up with that, and I'd like Dr. Tamimi to do that. But I want Howard to answer this first because I get this question a lot. How do you, as a physician, deal with negative feedback or negative ratings on social media?
Thankfully, I don't have a negative rating.
How would you counsel your colleague then?
I do. We brought in, he wouldn't listen to me or talk to me, but we did bring in a patient experience expert to sit down and talk with him.
Wait. Patient experience expert?
Yes.
Wow. Man. That's a social media job right there.
They do exist, and they're very busy.
Dog counseling
to try and get.
I've got issues that arena that I can help with.
But however, there are negative comments on certain blog posts, people who don't agree, and it really depends. There's all types out there. If it's someone who disagrees with my point of view, I'll engage them because I'm interested in their point of view. I just put out an opinion of mine, and I want to know why they feel that way. Then there are reviews that just go over the top. And
well, let me take it and turn it then. So what do you tell physicians who come up to you and say, Howard, I have this negative review about me. What do I do about it?
If you have an isolated negative review, one or two negative reviews on a site, I wouldn't even worry about it. I wouldn't think twice about it. You're never going to please everyone. I happen to be very lighthearted. I happen to be very jovial, very open, first name basis, and that's not going to make everyone comfortable. Some people want that I don't wear a white coat, I don't wear a tie.
You don't own a tie.
Uncommonly wear jeans. I do own ties. My kids use them for various things. And that's not going to please everyone. It doesn't necessarily incite a negative comment. However, if you start having review after review after review as not very pleasing, then you have a problem, and you cannot hide from that, period. I would simply ignore, or if possible, engage that single bad comment or poor comment, if it's possible, or you can ignore it safely.
Would you engage it privately or publicly? If it was a public statement, would you return it publicly? Vice versa? Pardon me to jump in.
I would, no, that's a good question. I would probably engage, it would depend on the tone of the critique, and I would probably engage it openly and publicly. If it was logical, if they had to wait a long time for some reason, etc., because I had a bad day, I was running late, and it's an atypical situation in my office, as you well know, I will engage that person. It really depends on the tone of the critique.
Well, let me ask Ferris, from a hospital standpoint, so how does Mayo Clinic deal with negative comments, and what advice do you have to hospitals about if they get a negative comment on their blog or Facebook or Twitter page?
Well, you can't delete it. I mean, unless it's still in the cache, it can't go in the trash. If it's there, it's there, because it can always be captured and replicated to some extent. I think responding to it is appropriate. You have the capacity to do so if your monitoring tools include someone who can. But if you can't, all of us have patient complaint departments to refer those issues to. And the appropriate response would be, I understand you made a comment on our Facebook feed or Twitter feed regarding an experience you had at the Mayo Clinic. Here's our patient experience individual I'd like you to contact and speak with, and make that response in a public fashion. But the tactical error is you just don't delete it. You can't do that. As far as individual comments, I think responding to those in a public forum is perfectly fine to do, but I wouldn't engage in a conversation. I would say, you know, thank you for your thoughts. You and I can agree to disagree, and leave it at that.
Lauren, so let me come back to you. As from a consumer and from a patient standpoint, how would you advise people to give kind of constructive criticism or advice, or using social media, to bring awareness to the problem, but not look very negative about it?
I hope you're doing it appropriately. Like if you're complaining about something that involved your insurance company and you're complaining on your physician's website, that doesn't really seem like an appropriate angle to be discussing that. Like, yes, that obviously is a complaint you had related to your visit, but what did that have to do with your physician unless it was associated with your physician's billing department? So when I look up things, I find often that those complaints seem to be present, especially in hospital settings, when you're looking at what people have to say about a hospital, either on Yelp or on blogs that are out there. But I would, hopefully, I would actually never do it publicly if I had any complaints. That's just my personality. I would want to engage the person personally to get a response from them and to come up with a solution. Maybe it was my misunderstanding, or perhaps it was just a bad day. So I actually very infrequently have any bad posts that I would ever put out. I tend to try and put positive posts out.
I do think there's a value, though, in a response in a public forum. I think we are
ignoring it is worse.
Is horrible. It's like in your marriage. You're judged by how well you listen, not by what you say.
Have you talked to my wife? Or no?
Yeah, I got to call my wife back when we're done here for a separate issue.
All right.
I want a new lawnmower. We're negotiating through that right now. But you are judged by how well you listen, and if you leave that comment and don't respond, you'll be judged by that as well.
And there's a lot of examples out there, and people probably know about it. If you're able to turn that person around, they could be your best advocate, whether you're a provider or a hospital or a physician. And
Delta Assist does a wonderful job.
Yeah. So it's a great question to get this part started. Other questions? Yes, go ahead.
My comments both as a journalist, writer, and as a patient. I appreciate, and I know that you love this podcast. I like to read. I like to think people listen as well. And I'm always frustrated when the information is only on video or podcast. Also because sometimes I like to again or and I just wonder if that's something that people think about or have that capability.
I think that's an excellent point. It reinforces the need for being strategic in how you engage and whom you engage with. And these tools are not one size fit all. I mean, Pinterest is a wonderful tool. I have a Pinterest page as well, but it's predominantly aimed at women, mean income 100,000, mean time on site 88 minutes a month, to make the majority of healthcare decisions in the household. That's true, but their interests are healthcare, wellness, healthy eating, child raising concerns and issues, and my repin rate for my posts on management of chronic mesothelioma are relatively low in that environment. So it's the wrong message fitted with the wrong tool, and you've got to be able to match your audience with your tool set with your message effectively. And it's not that complicated. You just have to think about it when you're strategic and be strategic in doing so.
You're absolutely correct, and similar to my comment where I said that social media use is cultural, so is your desire to curate content. And I actually put up a survey a few months ago. How would you like your content served to you? Short video, long video, short content, long content, etc. And short content and short video segments were equal. Long videos were very low and long content were very low. I have all my videos transcribed, and I put the transcript following a YouTube clip if I do that. And I typically will embed a YouTube clip within a blog post or within a content post so it doesn't sit there in isolation.
You have a preference on how you consume content, or is it, because I mean we had a lot of talk about mobile too, and a lot of people are consuming that way as well.
Well, no, I would say that we're probably all different. I mean, that's the end result, is that depends on what situation. If I'm at the pediatrician's office and they're going to give my daughter a vaccine that I kind of didn't read much about, and I have a few minutes between the pediatrician coming in the exam room and my daughter's not screaming yet, then I'll look on my smartphone. and look up just the little basic Wikipedia information. Or if I'm at home, I'll delve in deeper to see if I can get more further information. I personally like, since my scenario involves a lot of orthopedic questions, I actually like procedure videos. And then following, I guess my second choice would be something that's a written transcript, I guess.
So how do you have a process how you decide? I want, because you're very busy. So video versus text versus, or you just do it all, or you've told a story about Jeremy Lin and here in the New York area and how you wanted to get something out there, and can you share a little bit about that process, because you saw a lot of it out there, you wanted to say something about it. Can you share a little bit about that story?
About the Jeremy Lin story?
Yeah.
That was newsjacking. That is a nice technique to be able to share news in a timely manner with patients. Patients are going to be looking for that information at that time because Jeremy Lin has brought it to light, especially in the New York area. And so I put a quick post together and reference cross-link back to the more meaty posts within my site, as well as the videos that I had up in YouTube, as well as Vimeo. So I do take advantage of timely news subjects.
I've got a question for both of you. So let's say you're meeting with a provider who is not engaged in social media yet, and you want to help them engage in social media. They want to know time allocations and productivity expectations for each tool set. So how many tweets do you suggest on a daily basis? How much time should they devote to it? If they're going to commit to a blog, how frequently should they blog? How much time should they devote to that process?
When I talk to physicians and providers, I tell them when they start on social media, do not even tweet at all. And why do I say that? Because, especially for any good doctor, what they do well is listen. And to do good social media, the first step is to listen. So you start to see what's out there. You start to follow kind of what the conversation is. Like when you're at a dinner party or one of these conferences, when you go up to somebody, you just don't start talking. You listen to the conversation, you can see how you can contribute to it. And you can see the different communities out there. So whether it's medicine or sports or gardening or this or that, so you start by listening. And then there's going to be some point in that where you're like, I want to say something about this. And that's how you get people in. And you're like, I want to say something about this. And here's this news article to help back up my point. And, how do you do a URL shortener? Well, this is what it is. So how you get people in it is you start to have them listen to the conversation first, whether it's Twitter or Facebook. I tell physicians Facebook to start out with because they're usually on it for personal reasons, and I just have them try to follow conversations there and to like Facebook pages and to follow the conversation and then try to do stuff at that point. Twitter is very complicated to talk to a physician or provider who doesn't know anything. And in fact, I made fun of Twitter for the first year. I didn't tweet anything because I didn't really get it, but I listened for that year. But Facebook, for the most part, physicians kind of really can start to see what it is about, see what it is to post a picture, see what it is to post a link, and that's kind of how I tell physicians to start out with.
You're talking about personal Facebook pages or institutional Facebook pages, like a practice Facebook page, or?
Yeah. Okay. Yeah. Do you have first steps for physicians to start out doing this stuff?
You're absolutely correct. I mean, proper offline preparation is absolutely essential. You can't just wake up on Monday and say, I'm going to start a blog tomorrow and open up a Twitter account on Tuesday and a Facebook page on Wednesday. You have to be prepared. You have to understand HIPAA regulations and privacy concerns and sort of the rules of the rules of the road. And so I give the same advice to people. Don't tweet at all. Take one of my lists of either social docs or orthopedists or whatever you want. Follow them, retweet them perhaps, but stay silent. And same with Facebook. And on blogs, I offer to read their blog posts for them, to screen their blog posts for them, to show them how to blog properly, quote unquote. depending on their subject matter. I don't think there's any rules really, I mean, again, I'm there for altruistic reasons. I'm not there to sell anything. So, if there are weeks when I'll put up 3 blog posts and then I'll go a month without putting up any. It depends upon my bandwidth. It depends upon what I have to say, and it depends on my mood. But yet I'm very active still on Twitter and Facebook, regardless of what I do on my blog.
The other way I get physicians to buy in is at conferences. I was at a family practice conference 2 weeks ago, and we were tweeting out the conference. And people were like, "What are you guys doing?" And I'm like, "Well, I'm in 5 sessions at once. I'm not only here, but I'm in 4 other sessions." They're like, "How are you doing that?" Well, let me show you. And this is called a hashtag. This is the hashtag for our meeting. And if you put it on this thing, you can see what everybody else, see what all the other sessions are about. And it's like a little note-taking platform. So when you go home, and you can see what the whole conference was about. And it looks like you were everywhere. Physicians are competitive. They're like, "What are you guys doing over there?" I want to get in on that. And they're like, so especially at meetings, because especially at meetings, physicians love the live aspect. They love stuff happening at the same time. And it's overwhelming, but they like it at the same time. And what's also really cool is I got a lot of tweets from my family medicine colleagues at home who are in the office who couldn't come out to the conference and say, "Hey, I feel like I'm at the conference. And I can engage with people at the conference. Can you ask, the speaker about, this research? Because I have always been wanting to do it because I can't leave my practice for whatever reason. I want to take part in it." And with the conference people that I've talked with, and it's really anecdotal, I don't have any kind of scientific data about this, but what they've seen is that the next year, their in-person attendance goes up a little bit. And I've talked to people, like, "Why are you here?" Like, "I wanted to be here. Last year, I felt like I was here, but now I want to be here to be part of all this tweeting that's going on and to talk to people in real life."
I mean, the 2 things I think I heard you highlight are you've leveraged the conversation, extended it beyond the geography, not only to the providers, but other patients.
Right.
Who aren't there as well, who also party to that conversation.
Right.
And the profound value of networking. I mean,
Exactly.
you've been able to network to a dramatic extent, again, not limited by geography.
Right, and that's part of how I found my family medicine community, because we were at this conference and we got to see, oh, I'm a family doc, in rural Idaho, and I'm really enjoying the content.
Right.
And I want to reach out and connect with you, and that's powerful.
It is.
Yes, go ahead.
Just a quick question. Greg Lewis, I work at GKI. It's a healthcare CRO company. Really impressed with the amount of social interaction each of you are engaging in. I'm curious about Sermo. How do you come up with all here? You see that to be social?
Sermo.
You go first. I will follow, but I definitely have thoughts on Sermo. But go ahead.
There is a place for private networking for physicians behind a firewall. And I happen to be a big fan of Doximity for that purpose. But it is, you are who you are. I am Howard Lux. I am not Ortho 1. And Sermo is just an anonymous ranting platform, and it just, you just get annihilated by these very displeased, unhappy people who just have nothing better to do than to just crush you, no matter what you have to say. And so it's a very unpleasant place. They hit X 100,000 providers and then went downhill from there. And it has stayed steady, and they are not going to be around unless they pivot to a better model.
Yeah, I feel the same way. I've never seen the value of those firewall, password protected type of things. I'm more of I guess maybe my philosophy, more of an open conversation for everybody to kind of jump in on. And I've been approached by a lot of people to check these out. And for me, I haven't really seen the value of it. There's all kinds of stories on how they're done well. But for me personally, I just haven't seen a value in any of that.
What's very interesting is that on Doximity, I met a number of physicians. It's a collaborative platform of physicians, but again, we are who we are, and we know who you are. You have a very deep profile on Doximity, and a number of those relationships that took place behind a firewall, those physicians have now come out from behind that firewall, having become experienced and comfortable being online and expressing that themselves, and they've participated in online webinars with another company, and they've joined the Twitter crowd, and they are now out there and actively tweeting and sharing content. So it's a good place, it's a good way for physicians to become comfortable being online.
Was there a question up front here? No, okay, yeah, go ahead again.
I just wanted to make a comment on Thermo. I just wrote the newsletter on social media medicine, and I looked into Thermo and I could find a link, and I think physicians aren't aware that pharmaceutical industry is the government of the CNN. It's not a firewall that has people engaged with CNN. Basically, these doctors are engaged in
Correct. No, and they know that.
Yeah,
I mean, because I've read comments by a lot of doctors, oh my God, they don't read the fine print.
Right.
It's pretty crazy.
I agree, but there were a lot of conversations on Thermo where a lot of doctors clearly recognize, I understand, I know that they do this, I'm still going to come out here and rant and rave. I dropped off Thermo a long time ago.
Other questions, comments? I feel people kind of drifting away a little bit. So, let me think of a couple other questions. So Lauren, let me ask you, I guess your social media workflow, like, do you try to, like, how many platforms do you try to check out, or do you focus on a couple things, with your time and that type of thing? Or?
I have a good example that I'm not doing this all the time. This has not become a full-time job for me to check out social media in healthcare. I do it to my personal benefit, and I think that's the good and the benefit of anybody else that's experiencing what I'm experiencing. I think it has the potential to be, I talk to my friends about it. So yes, I'm on Twitter, but I'm very quiet there. I engage in Facebook, but only on a personal level, and barely a lot of information there. And I'm more becoming a part of it to engage and see what I can learn right now. So I'm actually at the point that you're talking about your physicians to go into. I'm trying to learn and see how I can be a part of this conversation. I'm sorry, but a big point actually to the benefit that I find, not just on Twitter or in my social media interactions, it's the conversation after my meetings with a physician. I find that a physician that's on social media is also more willing to engage if I have a question 2 hours after an appointment. Either it's an email. Howard has received many of these emails. I have a 2-hour drive home after I see him that I come up with a lot, unfortunately. But no, I mean, yes, I think that might present some fear to some physicians. We were talking about kind of the fear that is quelled by me coming in as an engaged patient, and that the physicians are also, there's less fear of the patient coming in engaged. But I think there's also a fear that when you are engaged, that they're going to want to talk to you all the time. And yes, I've sent Howard emails at 2 in the morning, but I am in no way expecting a response then. I just appreciate the forum of engagement, that I have a question and that at his convenience I'll get a return. I'm not looking for a physician to be necessarily posting, if they're a foodie, I don't need to know what you were eating last night. That can be for your personal platform to share. But I do appreciate the conversation at the end of the day, if it's something that didn't come at the main exam room.
Let me ask one more question, and if you guys have any follow-up. So as a physician and then as a hospital, how do you guys deal with these new social media platforms coming up every 6 months? Do you feel like you're missing out if you don't join right away, or how do you deal with new social media platforms that come up?
So I think once they hit about 10 million, then I think it's worth investigating and investing time in. So like Pinterest, once it hits about 10 million members, I think then, to me, that tells me that it has enough traction that I'm willing to commit time and energy to it. I can't do what Howard does. I'm not sure any of us have the capacity to. So I need some sort of metric or marker for both my own engagement at that institution, and 10 million feels like a good number to me.
I'll try anything. I mean, when VSnap appeared, I was on VSnap and produced, a VSnap healthcare video, within a day of them opening their beta. Same with Pinterest, etc. I check it out, see if it's useful, see if patients engage, if people engage, if people like it, and if they do, I stay there, and if they don't, I'm gone.
So you don't look at that as a permanence, like you're willing to try it. And
I'm not going to force it. Correct. I'm not going to force it.
So to close up day one, I'm going to ask you just for some closing thoughts from your patient, physician, and hospital perspective on social media. It's been a great panel already, but any closing thoughts or any topics or things that you want to say that we haven't already covered during our session?
I really appreciate being a part of this. I am in no way a representation of all patients, but I appreciate that the patient is present in this conversation, because I think patients are one of your end users, and whether it's somebody with an acute disease or someone with orthopedic issues or anybody, we're all patients at the end of the day. So if we can just make this all about the humanizing that Howard mentioned earlier and get us all kind of on an equal playing field, I think that social media has been a great way to have that conversation.
Howard.
I agree. Social media enables me to clear the windshield of doubt that you may have. It enables me, again, as I've said before, to humanize my presence. And although I get hit on this all the time on Twitter, we are all patients, or we are going to be. One day I'm going to look in a mirror and I'm going to see a patient looking back at me. As a physician who's fairly academic, I am going to know where to go. I am going to know how to curate information if it's not that acute of an event. And I want to level the playing field by offering you the education necessary so that you can make the same choices.
I still think the issue is when you meet with providers that you articulate clearly what operational need they possess in either policy or procedure that can be met with an asynchronous or geographically disparate tool. If you can identify that for them and then be facile with the tool set by trying those that have value and have credibility with them as well, that's the most effective way to engage them in that process. I mean, there are concerns regarding HIPAA and liability. Those are addressed by providing training and providing guidelines for your providers, rules of the road for their engagement. As far as the ROI issue, quite frankly, we're moving to a model that's going to have granularity for looking at physician performance to a greater extent than ever before. It's going to have transparency, so we'll have access to that data as well. And quite frankly, when that begins to happen, I think you'll see more providers beginning to partake in the process to a significant degree because they'll see the value in it. And that's the final opportunity for all of you, to be able to put the tools in place before that moment arrives so you're ready to address it. If you think about something simple like what I do heart failure, right? 30-day readmissions for heart failure won't be reimbursed in the future. Now, the most common reason that readmission occurs is because the patients don't comply with their medical therapy, either diet or medication. Dude, that's a perfect tool for social media. I mean, that's what this thing was meant for engagement after the fact, asynchronously, to ensure, yeah, did you take your Lasix? I mean, McDonald's rocks, but can we skip it this week? I mean, these are perfect opportunities. And when providers are forced to represent themselves publicly regarding 30-day readmission rates and have a tool available to them that can help address that, and you're there in their face with the training they require and the guidelines, that's your opportunity.
Great. So this ends day one. I'm going to turn things back over to Bunny. Thank you so much for your attention. Please thank our panel.